We're here at the 22nd CROI. I'm Fred Scheich with IFARA. We're here with Bob Grant with the Gladstone Institutes, UCSF, and the
San Francisco AIDS
Foundation. And you are, I said earlier to you, and do you mind me saying that you're the father of PrEP, because you kind of are in my mind. You've been there since day one. You've been, you know, fighting conceptually for this. And like you say, there are other people who have been fighting as well, but you're the one who did the work, got both hands down into it and worked hard to make this come about. And it must be rewarding to you to see where we are today, and of course, more importantly, where we seem to be going. Mm-hmm. Because it seems to be there's getting this traction now, more with PrEP today. It's becoming more of a trend, more trendy within the trendy community, mm-hmm. which is what we always figured was going to happen to make it really work. So how do you, tell us about the background, because I think this conference is so much about PrEP that we forget about some of the early work and the work that was put into it by you and others.
Well, thank you, Fred, for being interested, and I agree. I think we're at a tipping point in global acceptance of PrEP and its potential for ending HIV transmission as an adjunct to treatment and condoms and lubricants and communication and everything else that we know how to do. PrEP appears to be working well and among people who use it, and it has mm-hmm. collateral benefits. So, you know, in terms of the history, I think this is an idea that has many mothers and fathers, and I'm happy to count myself as part of the PrEP family and to have had a chance to nurture the idea along. I think it was really rooted in studies of maternal-to-child transmission or perinatal transmission, which showed that initially AZT could prevent transmission from mothers to infants. And initially, I think people had the idea that that was essentially due to effective treatment in the mother, but as time went by, it became more and more apparent that the AZT given to the mother was getting to the baby and helping with what amounted to pre-exposure prophylaxis around the time of birth. And I think that subsequent studies really showed that. We also have studies done in animals that initially looked at post-exposure prophylaxis and showed that it was highly effective when used in animals, and then pre-exposure dosing became an idea in the late 90s and early 2000s. And the reason is because post-exposure dosing is hard to start. You know, people do not always know when they've been exposed to HIV, and sometimes when they've had an exposure to HIV, even if they recognize that there might have been some risk there, it can be difficult to take action. Mm-hmm. In the way that
access to treatment, for one.
Yeah, and finding a pharmacist, finding a doctor, finding the wherewithal to, you know, get out of bed and start your post-exposure prophylaxis when you're still thinking about other things.
And the timing there is crucial. You have a short window.
For post-exposure prophylaxis, we say that it has to be started as soon as possible, and hours matter, but certainly it has to be started within 72 hours. Mm-hmm. And you know, I think it was because of that post-exposure prophylaxis was never widely used, because it really required that people act in moments when oftentimes they didn't even know where or how to get it.
Mm-hmm. Except in maybe a clinical setting where there was a needle stick or something like that.
Right. Yeah. But even, yes, exactly, in a clinical setting.
And then they usually use the drugs that the patient who they were infected by or ostensibly infected by to use as a PEP.
Right, and that's another point. In the occupational setting, you often know what the circumstances of exposure were, but not always. Mm-hmm. But you know, pre-exposure prophylaxis really came up as an idea to allow people to plan for sex and to plan for how they were going to manage their risk of HIV, mm-hmm. and how people were going to learn about ways to do that, including PrEP and PEP, before the emergency started. Mm-hmm. And I think that's the power of this concept, is it really gives people a chance to think about HIV and their sexual goals in calm moments over potentially multiple days. They can talk it over with friends, they can talk it over with doctors, they can get multiple opinions, they can hear from media, and they can go through this thought process of what they really want from sex and how they're going to minimize their risk for HIV over multiple days in calm moments. And oftentimes they choose PrEP. Many times they choose PrEP as one of the ways that they would protect themselves. So I think that's the, PrEP really is rooted in post-exposure prophylaxis, but it solves the problem in that it doesn't require that people act in emergency situations. They
just better planning.
Yeah.
It's just better planning. And I think for some people there's a concern about the pleasure of sex, and valid or not, I mean, it is their view, and they're entitled to that, and their perception or their feeling. And this is something that allows them to have a little bit more control over that seeking that pleasure that they seek.
Well, we know that condoms provide many benefits. They help prevent HIV, they help prevent some other sexually transmitted diseases. They can be used as a contraception, but some people who try to use condoms really are not able to use them all the time. Some people do not want to use them. And I think it is related sometimes to pleasure, sometimes it's a matter of control over the sexual experience.
Especially for women.
Women and bottoms, let's face
sure,
it. The condoms for the receptive partner is, the male condom is something that the top controls. And female condoms, I think, have been available, and there is some uptake of them. But I think people, sometimes seek more pleasure. Sometimes it's a question of intimacy and wanting to, share in the experience more. Sometimes it's convenience, sometimes it's control. I mean, there's limitations to condoms. And so I think just like with contraception, we need choice in HIV prevention, and PrEP is an excellent choice. Communication is always a good choice, and communication can be about HIV testing and viral load results and treatment. I think treatment as prevention is an excellent choice. Condoms is a good choice. But I think if we can offer people a variety of attractive choices, everyone's going to find at least one thing, and ideally two things, that they can use happily to protect themselves from HIV.
How would you approach and I think some people have tried, the roulette wheel. People are tending to still project that they do not want to have sex with somebody who's positive, because that's as though this is a finite thing, that they know this person. Whereas the people who are negative don't know they're really negative. Neither person really knows that they're negative for sure. And yet they may be both exposed, or one's exposed, the other one isn't, and they just don't know it. As opposed to a person who's protected, as we say, provides a community benefit, being on treatment and being protected with the treatment as prevention, or even PrEP. I mean, how would you couch that? Because we still have this criminalization thing going on. It's a tough issue.
I think sadly there are people who think they can avoid the risk of HIV by just avoiding HIV positive people entirely, or at least avoiding HIV positive sexual partners.
It's almost like a doctor in a clinic, or a dentist saying, I only serve negative patients.
Right.
How does he know this? And if he's not using universal precautions, he's at risk for greater problems than he wants.
So this is the problem, that people can become HIV infected before they know it, and they will typically go through a period of very high infectiousness before they're even diagnosed, because the viral load goes up very high. And so, we sometimes ask the question, which is a safer partner? Someone who says they're negative, or someone who knows that they're positive but has a suppressed viral load on therapy? And if you look at the data, the person who knows they're positive and knows they're suppressed is probably less likely to transmit HIV than someone who thinks they're HIV negative, but in fact has become infected and is in this very high period of exposure. But the other thing is that, you know, some people will say that they're on treatment and their viral load is suppressed, and that may have been true last year, but they may have fallen out of care, or they may have virologically rebounded, and they don't know it yet. And so the nice thing about PrEP is it gives people a chance to take control over their own risk.
Yeah,
and
it's almost as good. Well, it's almost as good as a condom.
Well, I think if it's used every day, its protective benefit is 99% among men who have sex with men. For women, we say it's about 90% effective when used consistently. So it's highly effective, and you know, it's as effective as condoms, maybe better. It really depends on. But you know what matters more is what are you able to use? And if you're able to use a pill every day, then that is going to be what works for you. If you're able to use condoms every single time, then that is what works for you. So, you know, what works or not is not really related to the thing. It's related to how well you can use it.
And the evidence is there. I think maybe what we ought to do is give the people the raw data. And say, this is the research, you know, guaranteed, this is what we learned. And then you can apply that as you see fit based upon the best information we have today. And we'll have better information down the line, always doing research. So it may twist a little bit, change a little bit, but we may have new interventions. We may have new treatments for rather than just using Truvada or whatever. It's just, it seems as though there's other research in the field. And the other thing too that I think, and maybe I'll let you speak to it, is the future is maybe injectables that are long-term acting, which would be a great opportunity to not have to worry about taking a pill.
So that, yes, that's a very promising concept for both treatment and prevention. There's several medications now that could potentially be given as an injection every month or every 3 months. And it looks like they might work for either prevention or treatment. Now that has to be proven, and the studies now are in the early stages. We're still looking at safety and acceptability, but you know, we maybe 5 years from now might look forward to a time when HIV treatment as well as prevention becomes a question of an injection every month or every 3 months. And that would be easier. Some people find that taking a pill every day is a burden. It's inconvenient.
Or if their lives are chaotic, and you know, people that are in a low socioeconomic level that just don't have the ability to manage their situation. They don't have a home consistently. It may be a really big opportunity for them to not have to worry about that.
You know, yes, you're right. And but let's not lose track of how people can take a pill a day. And the new information presented here at CROI really highlights that. We've seen a study done in the UK and another study done in France, both of which showed that adherence to PrEP, to oral PrEP, is possible. And that the vast majority of people who tried PrEP in those two studies took it consistently, and there was an 86% reduction in HIV incidence among everyone who took up PrEP as a strategy. And when you look at people who are actually using PrEP, there were no infections in those studies. You know, the 5 infections that occurred either occurred before PrEP was started or occurred in people who had started PrEP and then stopped for several months.
And even when they weren't totally adherent?
Even though they did not take a tablet every day.
Every single day.
And the Ipergay study really showed that nicely, because they didn't even ask their participants to take it every day. They just said take 2 tablets before sex, 1 tablet the day after sex, and then another tablet 2 days after sex. And in people who actually were doing that, they saw no HIV infections. There were 2 infections in the group that were getting the medication, the active medication, but in both of those people who became infected, they had stopped taking the pills entirely several months before.
So it really makes it, I guess everybody in the press conference was saying that really makes it 100% then.
If used.
If used, yeah, but that's what I'm saying.
But let's not trivialize that. You know, I think that everyone goes into this thinking, oh, taking a pill a day, that's super easy, I could do it, anyone could do it.
But you have to do it.
You have to do it, and it's a thing. You have to make accommodations in your daily life in order to fit in a tablet a day. And so what I ask people to do is to think of what you do. Think of something that you do every single day without fail.
Like
and it may be your cup of coffee or brushing your teeth or
yeah.
taking a shower. It could be checking your telephone for messages that came in the night before. But think about something that you do every single day and then put your PrEP bottle beside that thing. And so get into the habit of linking your PrEP use to something that you do every day. And you know, I've seen examples where, you know, it was almost every day, you know, like a fellow in my clinic, you know, has coffee every day except when he goes out for breakfast. And the PrEP tablets he misses are the days that he goes out for breakfast. And so we worked on a plan to say, well, you know, if you go out, put a sign. What he decided to do is put a sign on his door saying, going out for breakfast, take your PrEP tablet.
Or maybe have one of those little pill boxes that on his keychain.
Yeah.
And I don't know, but you're right. And you know what, I keep on hearing from some people, oh, adherence, don't do another adherence. We can't do enough adherence.
Yeah.
You've got to always have those messages going out because we need to be helpful to try to, if people are missing pills, they need to go into some sort of rehabilitation mode and say, I've got to figure out how to make this work better, because, you know, it's just like a lot of my cardiovascular drugs that I absolutely have to take every day. So it's important, if not critical.
Yeah, it's critical to also, though, allow for some forgiveness. I mean, let's face it, nothing in medicine works if you have to do it perfectly. I've learned that. I've been a doctor long enough. And the good thing about PrEP is that there is some forgiveness for missed doses. And we found, you know, that was important. And just stay with it. I mean, if you miss a dose, don't freak out. Just think through, you know, how am I going to avoid that in the future, and stay with it. What I hate to see happen, and it does, is that someone will miss a dose or two, and they'll say, "Oh, I give up." You know, I thought I was going to be a person who takes a pill every day. I'm obviously not, and
Get back on the horse.
You know, yeah, exactly. Get back on the horse. It's okay. It's okay. It's going to work as long as you stay with it.
Well, another thing is, we have a clinic in Portland for the county. We have a really good pharmacist, and they refer them over. So she has a consultation with them, really hits home about what the adherence means and what the drugs are that they're on, and how they need to be taken to be effective. Because every drug has its ability to be forgiving or not, or more or less. And so this is another discussion that needs to be had. So as we learn more information, in fact, I've had people that said, well, wait a minute, you told me it was forgiving to this extent. Well, we learned something different. And always be ready for new information to rethink or to reposition yourself as far as what a drug is going to do or how you need to conduct your life based upon the drugs you're taking. So it's important the messages you're giving right now to the audience is really appreciated, because it's to an audience that may never have had to take pills like in HIV. And it's just yet another HIV drug, but it's for people who aren't positive yet.
That's right.
In the case of PrEP, yeah.
And the other message I'd like to send is that these medicines these days are amazingly safe and well tolerated. I mean, sometimes we think that HIV medicine is as bad as the infection itself.
And it was.
It's so not true. Well, there was a moment. Yeah, there was a moment.
The taste test alone, oh my God. But those days are gone.
It's been almost 30 years of better and better drugs, and we're down to 1 tablet a day for HIV treatment and 1 tablet a day for prevention.
Keep on setting that bar higher and higher.
And the medicines are really well tolerated. I mean, people, you know, only about 10% of people will have any side effects, and typically they only last a day or two when they happen. The majority of people take these tablets
that startup phase where you just hang in there, it'll go away. And if obviously if it doesn't, you can hang in there for a couple of weeks. See how it goes.
And you know, and almost everyone after a week or two, those few side effects are over, and then, but the majority of people take these tablets and they have no side effects at all, and very happy with them. We do know that they have to be taken under medical supervision, and that there are some blood tests. Yeah, HIV testing is really important. We also have to monitor the function of the kidneys with a blood test, and that's a really simple blood test, just a blood draw every 3 months. And if there's some issue with the kidneys, then Some people have to stop PrEP for a while, but then they can restart it after their kidneys sort of get back to normal. And so it is something that should be done under medical supervision, but we're finding more and more efficient ways to do that so that it doesn't intrude into people's lives.
And the other thing that I want to make sure that we get out is that as the trials come down the line and you're asked to participate, or there's an opportunity to participate, do take advantage of it if you can, because it's a wonderful opportunity to be altruistic. You get something out of it because you're involved. You feel like good, you're doing something for the community, as well as yourself, maybe down the line.
Right.
So.
Well, and I think that's a key point, because we started by talking about folks who may no longer know anyone who's living with HIV, and yet we are all part of the same community. And I think that when we spend time together, we fall in love with each other. And PrEP research really gives us a chance, gives everyone a chance to participate in the bigger community that overcame HIV. And I'm thinking optimistically, but I think that we as human beings can overcome HIV. And but we're only going to do it if we live together and love each other, regardless of HIV infection status. I mean, it's just, and it's so much more fun that way. I mean, imagine going through life saying, God, I'm attracted to this person, but I can't because I'm afraid, and then you end up spending all your energy being afraid. And I think that if we can work together to overcome this epidemic, and by together I mean, HIV positive people, HIV negative people, all living and working and loving each other as one community, then I think we're going to have a lot more fun. We're going to find loving and lovely people, and we're going to end this thing. We're going to show HIV the door, meaning no new infections, and that people living with HIV live with therapy that prolongs their lives to near normal levels or normal levels.
Those are great words to close on. Thank you very much, Bob. Appreciate your time here.
Yeah.